All right, let's bypass the standard intros and just dive straight into it. We're running a rigorous, peer-to-peer clinical simulation today, specifically focused on high-yield diagnostic paradoxes. If you're aiming for that perfect 270-plus score, you already know that true mastery isn't just about memorizing facts. It's about aggressively exploiting the clinical variance. Today, we're tackling integrated, mixed-block scenarios designed to test your ability to separate the pure signal from all the noise. So let's jump into this explainer.
Module 1, Infiltrative Cardiomyopathies and Diastolic Failure. Let's get right to the mechanisms.
So, the absolutely crucial point here is understanding exactly what cardiac amyloidosis is doing at a tissue level. It's essentially the deposition of misfolded proteins, specifically AL or transthreatenin, also known as TTR, straight into the extracellular space. This physically stiffens the heart, creating a severe restrictive cardiomyopathy that presents clinically as right-sided or diastolic heart failure. But here is the diagnostic paradox, the exact trap they'll test you on. You'll see a markedly thickened left ventricle, paired strictly with a markedly low voltage on the ECG.
Notice the severe ventricular thickening demonstrated here. The immediate trap is to assume this is true myocyte hypertrophy, maybe from something like chronic hypertension. It is absolutely not. This extreme thickening is driven entirely by extracellular protein infiltration, not an increase in functional muscle mass. And that is precisely why the electrical voltage on the ECG actually drops instead of spiking.
Now, these systemic markers, they are literally your cheat codes. They mandate the diagnosis before you even think about touching a biopsy needle. If you've got a patient presenting with new-onset heart failure, and they also happen to have bilateral carpal tunnel syndrome, macroglossia, or periorbital purpura, the diagnosis is essentially handed to you. Also, look out for autonomic neuropathy presenting as orthostatic hypotension. It's another critical systemic marker that definitively separates this from run-of-the-mill heart failure.
In stark contrast, we need to talk about another infiltrative process, cardiac sarcoidosis. In this case, non-caseating granulomas are infiltrating the myocardium. While it absolutely causes restrictive failure too, the strict defining feature you must hunt for is the disruption of the His-Purkinje system. If you spot an unexplained complete AV block alongside restrictive failure, especially in a younger patient, you are definitively dealing with a granulomatous blockade.
This clinical variance box perfectly isolates exactly where these presentations diverge. We're looking at cardiac amyloidosis versus hypertensive heart disease. Both of these are going to cause severely thickened left ventricular walls and diastolic failure, but the variance, it's entirely in the ECG. Hypertensive hypertrophy features true muscle mass growth, producing massive, high-voltage QRS complexes. We're talking the S-wave in V1 plus the R-wave in V5 being greater than 35 millimeters. Amyloidosis, on the other hand, features thick walls strictly due to protein infiltration, creating that discordant, severely low-voltage pattern.
Moving on to our first integrated assessment on infiltrative disease. Rigorous integration is required here, so stay sharp.
Let's analyze this diagnostic matrix. We have a 65-year-old male presenting with severe right-sided heart failure. He's got bilateral carpal tunnel syndrome and waxy skin. The echocardiogram shows biventricular thickening, but the ECG paradoxically shows low voltage. You need to determine the absolute most appropriate next step in management based on this exact, specific presentation.
You really have to navigate these 5 distinct options by exhaustively eliminating the distractors. Option A, reassurance is obviously out for acute right-sided heart failure. Option B, serial phlebotomy and defroxamine, well, that's the targeted treatment for hemochromatosis. Remember, iron overload initially drives a restrictive pattern but frequently progresses to dilated cardiomyopathy, bringing that systemic triad of bronze diabetes, pseudogout, and irreversible heart failure. That doesn't match our low voltage and carpal tunnel guy at all. Option D, cardiac catheterization, targets ischemic coronary artery disease, which doesn't explain the systemic markers. And Option E, defibrillator implantation for WPW syndrome, that targets a completely different condition, defined by a delta wave and a shortened PR interval.
Which seamlessly leaves us with the winning mandate, Option C. The combination of thick walls, low voltage, and carpal tunnel perfectly aligns with cardiac amyloidosis. This strictly mandates an abdominal fat pad biopsy, and when you apply a Congo red stain to that biopsy, it's going to demonstrate that classic apple-green birefringence under polarized light, definitively confirming your diagnosis.
All right, Module 2, Myeloproliferative Kinetics and Cytogenetic Targets.
Let's kick this module off with polycythemia vera, or PCV. This is a primary myeloproliferative disorder. The crucial takeaway here is that PCV isn't just about having too many red blood cells, it's a primary, uncontrolled overproduction of all three cell lines. So you're going to see an absolute erythrocytosis, but it's right alongside leukocytosis and thrombocytosis. This absolutely requires targeted cytogenetic analysis to confirm.
The numbers really tell the story. A hematocrit aggressively exceeding 60%, paired strictly with an aggressively suppressed endogenous erythropoietin or EPO level, that is the unassailable diagnostic signature of polycythemia vera. Why is the EPO low? Because the bone marrow is just producing red cells autonomously, completely ignoring the body's normal feedback loops.
You also have to recognize the systemic burden of this overproduction. Look closely for severe aquagenic pruritus, which is that intense, maddening itching strictly after taking a warm bath or hot shower. You'll also see transient visual disturbances, facial plethora, and a massively increased risk of both arterial and venous thrombosis because the blood is just so hyperviscous. Splenomegaly is also super common. Ultimately, though, the whole diagnosis hinges on identifying the JAK2 V617F mutation present in about 95% of these patients.
Now, we absolutely must contrast this with the fusion oncogene of chronic myeloid leukemia, or CML. CML is driven strictly by the T922 Philadelphia chromosome, creating the constituently active BCR-ABL tyrosine kinase. The hallmark here is massive leukocytosis featuring an absolute basophilia, and the absolute pharmacologic mandate, targeted inhibition via imatinib. This clinical variance box is incredibly critical for the boards. You've got to differentiate CML from a leukemoid reaction. Both feature massive leukocytosis exceeding 50,000 and a left shift. But the variance is the key. A leukemoid reaction is basically an inflammatory or infectious response, featuring a high leukocyte alkaline phosphatase or LAP score plus toxic granulation. CML, conversely, features an aggressively low LAP score and an absolute basophilia. Let's lock this in with our next integrated assessment, focusing on systemic kinetics.
Here's the scenario. A 55-year-old male presents with massive splenomegaly. Labs reveal a staggering white blood cell count of 85,000, featuring a distinct 5% basophilia. Evaluate this massive leukocytosis and basophilic shift. What is the most accurate diagnostic test or immediate management step here? Once again, exhaustively eliminate the noise. Option A, standard cytotoxic chemotherapy, is a total trap. It completely ignores the targeted molecular driver. Option B, phlebotomy, targets polycythemia, not leukocytosis. Option D, broad-spectrum antibiotics would address a leukemoid reaction, but that absolute basophilia points entirely away from a simple infection. And option E, flow cytometry for TRAP, is looking for hairy cell leukemia, which is characterized by cytopenias, the exact opposite of our patient's massive leukocytosis.
So that logically leaves option C as the undisputed winning mandate. Targeted therapy with a tyrosine kinase inhibitor. This presentation of massive leukocytosis paired with absolute basophilia strictly defines CML driven by the BCR-ABL fusion protein. You have to immediately inhibit that tyrosine kinase with imatinib.
I'll leave you with this. Mastery of internal medicine lies not in memorizing the norm, but in exploiting the clinical variance. As you review these diagnostic matrices and prep for your simulation, ask yourself, are you just recognizing broad, easy patterns? Or are you aggressively seeking that singular variable that completely flips the diagnosis? Because that one variable is the literal difference between an average score and a perfect 270 plus. So looking at your own weak spots right now, which clinical variance are you still missing? Go find it.